I want to invite up to the stage some of really the most dynamic, most thoughtful, most important and influential policymakers in California healthcare, policy advocates and executives. To start, Don Crane, CEO of America's Physicians Group, Carmela Coyle, CEO of the California Hospital Association, Barsam Kasravi, Dr. Kasravi, Chief Medical Officer at Anthem Blue Cross, particularly the Medicaid plan, and Priscilla VanderVeer, Deputy Vice President of Public Affairs from PhRMA, out from DC. Come on up, welcome to the stage. Let's give them a round of applause.
Where do you want us?
Wherever you'd like, sir.
Okay. Hey, Carmela. Very nice to see you. Nice to see you. Good. Hey,
Where'd you like us?
Wherever you'd like, man. Appreciate you all being here. Hopefully the microphones work. Well, welcome. Let me start. Don, I'll ask you, and I'll preface my question to you with this statement. It's note to self. First of all, I was at your conference last week. Great job. I told you when I heard that you took over what is now APG, or America's Physician Groups, and there were 40 members, and you've grown it to 300, that is an impressive amount of success by any measure. So congratulations to you on that leadership.
Thank you.
I hope your board appreciates it. They should appreciate you. That said, I'm curious about what you're spending your mental energy on. Medicare, Medicaid, California, DC, contracting policy. There's a lot of stuff on your radar screen. Where do you spend your mental energy?
So I'd say all of the above, with particular emphasis. Our sort of core, most central issue is really the value movement, right? So the whole movement from fee-for-service to risk-based contracting, with capitation being the destination. That's where we spend much of our time here in California, and then across the country as well. We have members now, I think, in 45 states, but heavily engaged in Washington, D.C., where that is a big topic because of MACRA and the quality payment programs and some of the other initiatives that have been coming out recently from CMMI and CMS. So we're up to our eyeballs in the value movement.
Mm-hmm. And in a conversation we talked about last night, you said it almost, let me paraphrase and add a little bit more hyperbole so you can clarify, but it almost doesn't matter what the system looks like if you don't have the payment model between plans and providers right. It's very much, it's almost like everything else is almost like deck chairs on the Titanic. That's not your words, those are mine, but I'll let you tell me I'm wrong. That it's the model that is really, the payment model between providers and physicians that matters the most. Is that accurate?
So that's pretty accurate. Clearly we're highly concerned with whether it's single payer, all payer, or any other dysfunctional system we might pick. But what counts most is how care is organized and paid for underneath all of that, right? So we watch with interest and sometimes with horror at recent repeal and replace efforts and so on, all the while knowing that really the key to affordability and universal coverage really would be complete deployment of models that we are currently using that have demonstrated a lower total cost of care and higher quality. So for those of you that were in the session here 2 sessions ago that Bill Barcelona led with Richard Scheffler and Doris Naganahari, wherever you are, there you saw the data proving that at least across California, capitated integrated care, think of it as HMO, is vastly superior to fragmented fee-for-service, think PPO care, by a wide margin across a whole bunch of quality measures, and then maybe most importantly for many of our conversations, in terms of total cost of care. So that includes the co-payments and the co-insurance and the deductibles. And as we look at that picture, Richard Scheffler here has done the arithmetic for us. Were we to deploy that model across all of California, the savings generated by doing so would be more than sufficient to overnight produce universal coverage. Now there would be barriers, there would need to be subsidies, you'd have to wrest profits from health plans, you'd have to get waivers, but we're over half the way there in California in terms of a solution. And so the better solution is get to the delivery model. Let's get this fee-for-service behind us. Let's get to the value models, and we'll have a much better system that will serve our citizens much better.
So, Carmela, welcome. Thank you for being here and joining us. You obviously have joined the California healthcare conversation from a prior stint at Maryland. You were senior vice president for policy at the American Hospital Association. You've been in all of these different types of conversations, and I will say that everybody I've talked to, because I've asked, says wonderful things about your work here so far, chatting with folks and getting to know the state. Where do you sort of put Don's thesis about the payment model really essentially needs to be some sort of HMO or capitation model? Where do you put that thesis within the broad strokes of your experience, both at AHA, at a unique kind of all-payer rate-setting model in Maryland, and now what you know about California?
Well, and thank you. It's a pleasure to be here. I like parts of Don's thesis. That is, I couldn't agree more that the most important conversation we can be having right now is about understanding how to create the right incentives, not only for providers to work together, but for providers and non-healthcare providers, talking about the social determinants of health, how we can all be working together, how we align those incentives. I think Don's experience in the HMO capitation world are well documented. I think in my own mind, there are other models out there, and it may be a mix of models that are ultimately successful. However, they all need to focus on the value of healthcare, so moving from volume to value. As Don has said, the future is all about the total cost of care. It is no longer about per unit cost of care, and it's no longer about a particular sector's cost of care. So there's a lot that I agree with. I think there are some models, given my experience in Maryland, obviously, a 40-year history with all-payer rate setting, not anything like AB 3087, currently discussed here in California. About 4 years experience with something called global budgets. That's where Maryland transitioned. It's not capitation, but it's another variation of capitation. But it has those same incentives to really give organizations an incentive to focus on population health, to focus on prevention and wellness, and to keep people out of the hospital to begin with. It has shown tremendous savings to the Medicare program. I think there's some experimentation there as well.
So I think a lot of people who think about health reform look to Maryland and say they've done a lot of good work for a long time. The rate setting commission has been generally very well accepted. I think it's still the only one left in the country, or one of the only ones. There were a number at a time. And this sort of global kind of budget, not capitation quite like you had said, but a global budget model that under Maryland's current waiver has gotten a lot of attention as well. Parts of California might be like Maryland, since it could fit in a couple of times to the state here. What are the lessons from your experience in that progressive system that best apply within this rate setting conversation or global capitation conversation? What's the smart parts that we need to learn about?
And I don't want to be misunderstood. I'm not certain that Maryland is a recipe for California, but to Don's point, there are experiments, more than experiments, out there now that have shown results. I too lean where Don is. Let's focus on those things where we have results, we have data, and it is about spread and deployment of those models. So what have we learned in Maryland? To try to do this for one sector is not successful. Maryland is an entirely hospital-focused set of conditions. That doesn't work. We all need to be in the same boat, rowing together in the same direction. So we've got to think about models that really look beyond just one sector or another. I will say that we learned quite a bit in understanding what kinds of incentives do you need for organizations, providers who are on the downside of volume growth versus those that are on the upside of volume growth. As an example, global budgets used in Maryland really saved rural health care in the state of Maryland in a way that was not particularly costly and avoided some of the market behaviors, some of the competition that was quite frankly adding to cost, not doing what we needed to do for those populations. Are there lessons to be learned there for other rural settings in the United States? They're experimenting with it right now in Pennsylvania in some rural hospitals. It's being looked at in some other states. Might be something we want to consider here. So lessons learned. It is all about the data. It's all about aligning the incentives. I think there are models that we can and should continue to build on.
Yeah, interesting. Barsam, let me ask you, I know you focus on Medicaid, and Anthem does a lot of things in a lot of states across a lot of lines of business. Do you tell us about some of Anthem's strategic thinking vis-a-vis plan-provider relations? We talked a little bit about this from a hospital perspective, from other provider perspective. I'm wondering about a plan perspective. How does Anthem Medicaid feel like it can best engage providers in a conversation that leads to all of the outcomes we want in terms of lower cost, better quality? What are some of your learnings and thoughts as a physician, now as a plan executive also, in terms of that plan provider piece?
Well, thank you, and good afternoon, everyone. No, as I was listening to the conversation, I think, as a physician and also being at Anthem, having moved from the commercial side over to the Medicaid side, I think aligning incentives is the beginning of that evolution, but we're thinking more at Anthem, how do we align tools and skill sets? For example, is capitation enough to get that Medi-Cal physician the tools to manage the complex members that they're facing? And in line with Carmela's identification of the social determinants, the physicians these days don't currently have, in our opinion, all the tools they need to manage the complexity of not just the clinical, but the social and even the pharmacy piece of their patients. So at Anthem, we believe in that financial incentive and how do we get that right. And there are a lot of pilots currently, for example, the Health Homes pilot, other pilots where we're trying to, incentivize physicians, capitate physicians, physician groups. But we also want to say, what other tools do these physicians need? Do they need population health tools? Do they need, infrastructure? Do they need allied physicians, physician assistants, nurses, access to transportation, access to not just data, but, and then not only physicians, but are there other types of providers we need to bring in and integrate into the mix, whether it's long-term services, whether it's physicians or care at the home. So we're looking at it globally. We're saying, yes, we're a payer. We want to understand the financial model. But as a clinical team, at least my team, we want to also say, how can we support the provider community with all the tools and resources that we have and really align the tools in addition to the financial model?
How does the learning from Anthem's commercial side, particularly around things like narrow networks and Vivity and that kind of momentum, how does that inform the stuff that you do on the Medicaid side, particularly again as you look towards this procurement next year? Is there bleed over of wisdom from one line of business to the other, or is Medicaid sort of a world apart?
I think there's some overlap, but there's also some differences. So, definitely there are differences in some of the physician networks out there. The tools that the Medicaid physicians have are not always the same tools as the commercial. And the commercial patients used to be quite different than the Medicaid patients, although I think that line is blurring. Right now, a third of Californians, as has been mentioned, are now on Medicaid. So I think as the years have gone by, in the 11 years I've been there, it used to be, okay, commercial is over here, Medicaid's over here, Medicare is over here. But we're seeing that line blur more. We're seeing a lot more overlap on not just the provider network, but also the members. They go from Medi-Cal, sometimes they go to the exchange, then they go to commercial. That fluidity is there. And so at Anthem, we really want to prepare ourselves to be able to manage that member, not, almost like line of business agnostic, and really manage them based on where they are in that continuum. So we're seeing much more of that overlap, I'd say, in the last 5 to 6 years than we had in the past.
Priscilla, thank you for coming all the way from Washington, D.C. Appreciate you being here. Why don't you put for us in some context the conversation around health reform in California vis-a-vis the other states that you track on behalf of PhRMA? How would you characterize this conversation? Is it cutting edge? Is it maybe a little dated? Is it, what are your words?
So thank you all for having me. It's a pleasure to be here, and thank you, DJ. I think that one of the things and one of the reasons why I spend a lot of time in Sacramento and a lot of time in California is the fact that California does take the lead on a lot of national measures. You often are the ecosystem where things start to grow. And so from our perspective, monitoring what happens in a state like this is really important, including from the federal level. I think all of this conversation and what has been said so far, the key thing here is from every aspect of the business side of healthcare, we are all having to adjust to the new world that we live in. And whether that's because you have different laws in different states, or whether you don't have clear guidance from the federal government on what you're supposed to be doing and how you're supposed to be doing it, the requirements of our business is to be adaptable and willing to change, because the market's going to change with or without us. And so you have to be flexible in doing that. And I think from our perspective, we've spent a lot of time over the last couple years talking to stakeholders all over the country. And you know, when we got a new CEO late in 2015, his focus was, you know, everybody thinks of pharma, and I'm sure if I say this, nobody in the room will be surprised, as oh, we can't do that. No, that we only say no. And our CEO, he charged our staff and our industry with identifying solutions to some of the problems that we've all talked about here, but on a much bigger scale. So yeah, we're in this incredible new era of medicine where we are seeing treatments we couldn't have dreamed about 10 years ago. Things like CAR T and personalized medicine and the use of genomics. And the reality is those things are incredibly expensive. They are not chemistry drugs anymore. You're talking about literally removing cells from the human body, changing them and putting them back in. And so the question becomes, how do you pay for that? That's a really important question to answer. I think a lot of our companies are coming to the table trying to work with health plans to figure out, if it doesn't work, you don't have to pay for it. This idea of the value conversation is much more advanced than it was even 18 months ago. And talking about that. And that is, I think, a movement that we're seeing. A lot of states are taking the first steps in that. We've seen this in Massachusetts. We've seen it here. And, you know, the federal government seems to be trying to catch up with that to a certain extent. But all of those things are all interrelated. And then the other point I would just make is there is no way that we can continue on in a segmented conversation where everyone's pointing the finger at everyone else. I think we all have to come to the table with some of these solutions, and the states are forcing that to happen, including California.
So let me ask you, you know, I think your point about this sort of change in from chemistry to other forms of treatment is already beyond my imaginations. Like the stuff I hear about, I can't even, you know, I'm like stunned, right? And it's changing so quickly, it's only going to get more stunning. And we're going to have more of those conversations about how do we continue to deliver those services to people. So this is an impossible question, and I don't expect like a coherent, complete answer, but I'm interested in sort of your general thoughts. What is that sort of value-based conversation, or how do we pay for it 5 years from now when it's not just a couple of gene therapy, you know, treatments that are on the market? It's like 1,000. And if it's my kid, I want whatever my kid needs, right? What is that conversation going to look like? Recognizing that if you guys can come up with solutions at PhRMA, you know more about it than I do, for instance.
Yeah, definitely. And I think the first place I would start is the fact that one of the places in healthcare, and I promise that this is true, and I can show you the data that shows it, but for the most part, over time, the only place in healthcare where costs go down is medicine. And the reason that happens is a couple. One, we have competition enters the market. And so the drugs you're seeing now that are coming out in those prices, as additional products come to the market, the price will come down. This has been proven time and time and time again. So for example, when the first hepatitis C drug came out, it put everyone in an uproar because of the price. I could argue, I don't think that was warranted because it was a cure for an incredibly expensive disease. But also what happened in the same year was multiple competitors coming on the market. That drug now, those hepatitis C cures today are cheaper here in the United States because of the private market competition and the negotiations that take place in our system than they are in Western Europe. And more people can have access to them here. And the hope is that if the incentives for our companies to continue to research and develop this new generation, this new era of medicine, if we can continue down that path, that competition will show up in the marketplace. We're also having very in-depth conversations about bringing more biosimilars to the market. You know, biologics are inherently difficult to create. They're very difficult to manufacture. They are living organisms, and they started coming out, 12, 15 years ago, and now you have companies, including our companies, who will begin making so-called generic versions of those products and bringing the price down.
Yeah.
It's been very difficult to get companies to, even generic companies, to look at making those products because, like I said, you have to have the equipment and the expertise and the ability to make biologic drugs, and generics just haven't had that. So how do we make sure that there are other companies who are incentivized to bring those products on? So in 10, 15 years, it's incredibly common to have a biologic that is a generic market, just like you would go and get your penicillin or the vast majority of the drugs that you get on the market today when you go to your pharmacy.
Yeah. Carmela, let me ask you sort of about this cost and market question that Priscilla tees up. The ACA has catalyzed consolidation in both the plan and provider space to a very significant degree. Senator Hernandez this morning essentially said that the market's response to the ACA was, in part, consolidation. It sort of depends on where you sit. Sometimes not you, but where one might sit, their perspective might be different about that. But generally speaking, we're seeing consolidation across a number of markets. Is that good? Is it bad? Where are the sideboards? What should we be trying to feature and focus on? What are your general thoughts?
Well, a couple. I do think that we are attempting to paint all merger and consolidation as bad. I don't believe that, and if we look back in our history, that hasn't been true, whether that's in healthcare or any other space. I think what we're challenged to do is to really accurately measure the benefit and the change that results from that merger and consolidation. What I can tell you is that certainly from a hospital perspective, hospital leaders all across the United States are trying to understand how to take, if you will, unnecessary cost out of the system. Certainly, merger and consolidation is one way to achieve that outcome. I think the conversation from a more political perspective has been ultimately what happens to the price of services. I'm challenged, just again from the hospital perspective, the majority of prices out there, Medicare and Medicaid, are already set by others. I do think that this government underfunding that we have lived with for so many years is really the key driver of what pricing looks like for privately insured individuals. So it's certainly one approach that's being used. But if we take a look at the Medicare program itself. We used to have one quality improvement organization in every state. What did? They consolidated, they regionalized, because somebody said, why are we doing this 50 different times? Aren't there some economies of scale? So I do think we have to look at it more carefully. I do think that accountability is important, that we've got to understand, and we do have regulatory processes to oversee these, right? Both at the state level and at the federal level. It is not easy to bring large organizations together. But then I do think it's fair to say, let's watch that over time and understand what the implications are. I think what's a little more than a little unfair is to suggest that any coming together is a coming together for a monopolistic power, rather than for an effort and a real, a real true-spirited effort to say, can we take unnecessary cost out of the system?
Do you think it's because the ACA has at a minimum catalyzed some of this market action, do you think it's fair to say that it's time to review regulatory structures to maybe realign some of those, either from procurement or oversight, to better be able to manage this newly consolidated, newly complex, or increasingly complex? And the market has moved ahead. Does the regulatory world need to be updated, do you think?
I guess that's not where my head is. I also don't necessarily share that it's the ACA that is driving this. I don't think it's the ACA. The Affordable Care Act is driving broader coverage opportunities for individuals, not access coverage, maybe we can come back to that, but broader coverage opportunities. I do think it is market pressure. And it's market pressure among the folks that are on this stage in the private sector. It's market pressure by government payers that I think is really driving organizations and provider organizations to look at and consider new models where we can actually, to Don's earlier point, drive the value to consumers.
Don, we spent all this time since 2010 talking about the ACA, and of course we've got this state-based conversations as well related to single payer and all of those things. You've said that you think Medicare is going to be a far more dynamic catalyst, MACRA in particular, and the recent sort of slipping in of the Chronic Care Act into the budget deal. First, tell us why about that Chronic Care Act, because I think not everyone knows about it. And then maybe just explain, why do you think Medicare is going to be the driving force?
So, the Affordable Care Act, very, very important, but to the point made earlier by a number of people, it spoke mostly to coverage and access and financing, and it's in the rearview mirror now. More important, I think, for our purposes here, really, certainly our purposes, is MACRA. That's the tailwind behind the value movement right now, and that gives us MIPS and APMs and so forth. So, and it's Medicare. It speaks to Part B, which is a huge part of the marketplace. So there's that. Next, there's Medicare Advantage, which is growing by leaps and bounds, beyond all predictions, frankly, because it's so popular and it's producing such good results, higher quality, lower total cost of care. So there's that. Next, you watch, I think, kind of a conspiracy almost between science and the market, which is shifting where care is delivered. So we increasingly see it in ambulatory settings and increasingly at home with remote monitoring. I think that kind of a force, when added to these other ones, will make a lot of difference going forward. So it isn't just monopolization isn't the only thing going on out there now. We have all of these other forces at play. Did that get to your question?
Yeah, but I'd also like you to sort of explain the flexible benefit design that will now be allowed in certain Medicare.
Oh, we're talking, well, this is important because there's been earlier sessions on social determinants of health. So that's been an area I think most all of us has realized is a really important front, and that we can drive lower system costs and improve quality of care generally and for the individuals if we better address social determinants of health. We've been prevented from doing that in Medicare Advantage because of some rules that limit the kind of benefits that can be given, et cetera. That all changed here recently with the bipartisan budget act that's now, 2 months old or something, that added provisions that allow supplemental benefits in Medicare Advantage, namely social determinants of health generally, but more specifically, social work, nutritional support, transportation, home visits. Those things were prohibited, hard to believe, you guys, previously. They're now permitted. There's now a funding source. So you'll see health plans including those costs in their bids going forward, and then delegated groups around the country getting into social determinants of health, and I think making a big difference, and get ready for really good results in terms of total cost of care, system costs, and I think it will help blaze a path for other programs and products that will follow.
I think this is among the more transformational things that's happened in healthcare that nobody has picked up on, is that Congress has now allowed Medicare Advantage plans to start including these benefits, pricing them, paying for them, getting into non-traditional provider spaces. We think of Barsam, we think of Medicaid, Medi-Cal as being a dynamic force and a flexible in many ways, not necessarily a flexible benefit model, but a flexible payer. Do you see, with procurement on the horizon, I know I'll ask Jennifer Kent this type of question later, but do you see sort of a newfound flexibility in Medi-Cal, or any sort of flexibility, or do you feel like this procurement might be a little more of the same, maybe a little bit of a diminished opportunity. What are your thoughts there in terms of being able to meet social determinants for the Medi-Cal population as a result of the next procurement?
Yeah, that's a great question. So I think to Don's point, social determinants has been a concept, I know, at least in the Medicaid space. And back to my earlier point, the 1115 waiver, there's a piece in there, whole person care, as well as the health homes, which is part of the ACA. Both of those went directly at the social determinants concept. And actually, that was the time where health plans, at least in Medicaid in California, really had to think about how do we support social determinants. And it's really a challenging area. I mean, there's areas like homelessness, substance use, poverty, behavioral health beyond substance use, addiction. And so it's really challenged Anthem and other Medicaid plans and now Medicare, I think, to really say, okay, we know we have to tackle these social determinants. We've historically, when I was on the commercial side, we'd manage CHF, readmissions was based on CHF, multiple different chronic illnesses that would create readmissions. But now we're saying, well, maybe it's homelessness that causes readmissions. Maybe it's not having a car to go to your PCP appointment that's causing readmissions. It's not so much clinical. So I think that, Medicaid, the waiver and the other components of the ACA have brought Anthem and other plans to really understanding the social determinants. So to your point about procurement, I think the bar has been raised of what health plans have to do in the state of California for the next decade. And I think when we get to procurement, it's no longer going to be, are you doing your preventive care visits, and are you reducing readmissions? It's going to be, how are you tackling homelessness? What is your opioid program, and how have those results generated benefits to our community? It's going to be county specific. It's really going to be, where are the plans with respect to improving the life of the community? And that's beyond, the clinical piece. So,
Carmela, healthcare sometimes takes a generation to change. It's not just the battleship that takes time to turn. It's the whole flotilla has to stop and then turn and then go. So it takes time. But I'm wondering, a generation ago, I think a hospital executive was a heads in beds kind of person. And now there is change in that leadership culture to a much more community-minded and non-traditional approach. Where are we in that sort of transition? I mean, is the hospital executive, who is very community-minded, still kind of the exception, or is that really infusing the new generation of folks who are coming up? I'm asking about the culture of leadership at hospitals and how well they respond to social determinants.
And I want to tie it back to the social determinant issue. Of course, my bias is, I think, what attracts leaders to healthcare versus any other complex organization they might run is because they are community-minded. It really is mission-driven. So I see that. To your point, we have seen a shift in the degree of attention and focus to things outside a hospital's four walls. So, that iconic blue H no longer just means hospital. I'm grateful for those, by the way, because I can find where I'm supposed to be going. But that iconic blue H is no longer about hospital, it's about healthcare. I do believe that for hospital leaders, not only here in California, but across the United States, and I have the pleasure currently of serving on the American Hospital Association's Board of Trustees, this is front of mind, but it's front of mind because of an understanding that it is the key to the affordability of healthcare. So to the conversation that was just had around the whole person care model, I think that's a great opportunity for us in the state of California, but it is still structured as a separate bucket of money. And so what's bringing people to that conversation is access to that separate bucket of money. The key is to tie that incentive into the payment received every day. And if I may use Maryland, I promise not to do it again, as an example, the global budgets that hospitals work under, and that means every hospital receives one amount of money for the entire year to treat anyone who comes to their doors. So it's not per capita, it's one amount of money for anyone who comes through their doors. But the most immediate change that happened to say, all right, how do we keep people out of the hospital was transportation. And it wasn't transportation to the hospital, it was transportation to your primary care appointment. The second change that happened was medications at the bedside, eliminate the opportunity for someone to leave the hospital and never get their prescription filled. And the third was this broader reach, largely on behavioral health, where we actually saw hospital leaders embedding their senior personnel in community-based behavioral health services, because what rose to the top of the list in terms of unavailability were all of the behavioral health needs that we know we have in our communities. So it's about changing that incentive. I do believe that all of us in this room have in our hearts, the notion of doing the right thing by the individuals that we have the privilege of serving. What we now have to do is get the right incentives aligned behind that, and then it's pedal to the metal in California.
And is that something that can happen absent major state policy leadership? In other words, that kind of model that fundamentally, started sending the transportation away from the hospital rather than to it, required both leadership and a policy structure to happen.
Absolutely. I think partnerships are key. Partnering with the state is key. Partnering with Medicare and the Center for Medicare and Medicaid Innovation is key, but none of those innovations work if the state isn't on board, if, quite frankly, all of us and everyone else in this room isn't on board for, as Don can talk about, experimentation. I think one of the greatest challenges we have is that the federal government, Medicare and Medicaid, as they're interpreting these experiments, are really treating them like done deal programs. And there's much that we're learning in the demonstrations that we ought to be able to say, okay, that didn't quite work. Let's turn that a quarter turn and try it again. So we need to really approach this, I think, in an even greater spirit of experimentation.
Priscilla, we're getting short on time. I'm going to ask you first a question I'll ask each of you. This is very much a manifestation of the type of multi-silo approach we try to foster at State River Reform. And so within the context of a multi-silo offering, what advice or counsel would you give this group as they lead their organizations and try to navigate this time of transition and uncertainty in healthcare?
Sure, I'll make three very quick points. The first one is, and I think we've gotten to it towards the end of this conversation, and it's about the fact that you don't get into healthcare because you don't care about people. You do this, and you do this work, which is incredibly difficult because you do, and making sure that we all continue to focus on the patient. I said to you before the panel, I think Medicaid managed care is frankly a really great model for how to deal with patients who have these very complex lives, complex conditions, and keeping that in mind as we all move forward in whatever it is, whatever world we live in healthcare is important. The second one is you have to be willing to change. You may not want to. I think you just spoke to this in Maryland. I live in Maryland. I was just in the hospital in Maryland a few months ago. Great work.
Hope it went well? Oh, good.
It went great, thank you. But I will say that for our purposes, we made a move last year that not a lot of people know about. PhRMA at one point had over 50 members. And one day we decided, you know what? We want to represent organizations that are swinging for the fences in innovation and R&D. And if you're not investing a certain threshold of your budget into R&D, you are no longer a member of PhRMA. We lost 22 members in one day.
Wow.
We've never done that before. It was a big thing. And not a lot of people know that, but we felt like it was important for us to put our money where our mouth was and really take a stand on the fact that we don't represent the hedge fund managers who are increasing the price of drugs 5,000, 6,000% for no other reason than that they can. And then third, I would just say I hope that the way that you have your conference here and the way that we've all spoken to each other and the way that it's a respectful conversation where we try to find solutions, I hope that we can continue that. We certainly don't have that dynamic at the federal level in any way, shape, or form. And I think states don't have choices but to pass budgets. And we should really look at that model as we have to get this done, we don't have a choice, and we need to work together to do it.
Good, thank you. Barsam, same question. What advice or counsel would you offer this group of diverse perspectives about how to lead their organizations moving forward?
First, I think, DJ, just getting the four of us together, I think we should send you to North Korea next after getting us all.
I might not come back. Priscilla just said she wants more of these.
I think everyone focuses on the C for cost, but in the recent years in Anthem, I think collaboration is one that is actually very challenging to do. I think collaborating, even internally with another team, we have a lot of silos like every organization, but I would just say, really study collaboration. What does it mean to collaborate with a culture that's different than yours, whether it's a hospital, a payer, a provider group, and each provider group is so different. Anthem Medicaid, we're in 29 counties. We have thousands of providers, and we're trying to collaborate with our counties, our communities, our stakeholders, and every collaboration requires effort, building that relationship, understanding the incentives of the other party, and trying to align those incentives, and then actually getting something done, following something through to the completion, and then measuring that. So I would say focusing our energy on collaboration, which means challenging ourselves. How can we be better? How can we open up what we've been doing in the past and open to change, but also really understanding where the other sectors are coming from, whether it's pharma, hospitals, providers, or other parts of the county or the community, whether it's the homeless organizations that are coordinating care for the underserved, whether it's the county behavioral health. There are so many sectors in healthcare that I think studying where everyone's coming from and what their incentives are, and then helping that collaboration is really the only way we can get this done.
Great. Don, counsel or advice to this audience?
So, and I'll be a little contrarian on this, so I would never for a minute say we shouldn't experiment. Experimentation should always be a part of growth. But I think the better tactic, at least nationally, and in California as well, is to find examples of where something's working very well and then imitate it. I mean, you have to flex a little bit, but imitate it. So we watch with frustration, for example, some of the alternative payment models coming out of the Innovation Center built on faulty models and so forth, and they're having lackluster results. And we watch with frustration because we know that better results are being delivered all across the country in better designed systems. So there's that. I think my sort of final bit of advice is, so much of our concern here is appropriately with Medicaid, Medi-Cal. The Oregon experiment with CCOs right across the border is astonishing in terms of blending in social determinants, behavioral, dental, under a global budget. There it sits right up the coast, having excellent results. I would recommend we study that very hard and imitate it where it makes sense here in California. And that approach also holds a lot of promise, finding what works and imitating it.
Carmela, final thoughts?
Wow, hate to hit cleanup on this one. So my first thought is the status quo is not a winning strategy. My guess is many of us know that. It's one thing to say it and another thing to lead that.
Yeah.
That's very difficult. Second, we all have to get comfortable being uncomfortable. Change is difficult. It does mean we're going to have to go into this future not knowing all of the answers. I really want to underscore Don's points, however. We do have some data, we do have some information. That should really be our guide. It's not let 1,000 flowers bloom, it's focus on what we know is evidence-based. But we're going to have to be comfortable being uncomfortable, because I think we're going to see things that are directionally correct, and we may not have all the answers, but we may have to jump anyway. And in that world, it's that sort of, as a friend of mine used to say, 1 foot on the dock, 1 foot on the boat. We're going to have to ride this uncomfortable space until we figure out what it looks like. So my last, this won't be popular, is patience. I think all of us, and especially our elected officials, and I understand it, but all of us in our communities and in our homes, right? We want this fixed now. We want it changed now. And we could run great risk by doing the wrong things. So I think we want to move, as I said the other day, with alacrity, but we want to do that thoughtfully. So putting that together and getting us all working together would be helpful.
Carmela Coyle, CEO of California Hospital Association, Priscilla VanderVeer, Deputy Vice President for Public Affairs at PhRMA, Don Crane, CEO of America's Physicians Groups, and Dr. Barsam Kasravi, CMO at Anthem Medicaid. Let's give them a round of applause.